Thank you, Meena. That was terrific. We have time for a few questions, and I'll take the prerogative of the chair right now and ask the first one. David and Meena, both of you have sort of put forth a vision of a more holistic, more coordinated approach to serving this population. And what I'd like you to spend a moment on each, perhaps, is the question of what evidence do we need to know about which levers to pull most urgently? And I want you to start off, David, if you.
Yes, I think, and Meena spoke about this a bit, about some interesting opportunities within CMS. I think the first is that we've got to recognize that the care needs to be comprehensive. It needs to pay for non-traditional types of care, such as that provided in community-based organizations, and care that doesn't result from discrete services. It's more of a continuity types of thing, and there are many uncovered services. So there's been some discussion, and in fact, there's legislation in Congress right now about CMMI doing a demonstration project or studying alternative ways to pay for alternative payment mechanisms for dementia care. And dementia care is just different. It's different because the person living with dementia cannot participate frequently, particularly at the later stages of the disease. It's different because of the tremendous psychosocial, behavioral complications. It's different and needs a different approach.
Yeah, and I would say, starting from the very, high level, as David mentioned, where there are those different approaches that are being tried, who are the patients that this is being targeted for? What is the impact of it on all aspects, on well-being, on patient-reported outcomes, family members, on health outcomes, on utilization and spending? From that high level, to give an example, I think there's been a lot of movement of bringing care into the home. And, as with COVID, we were dealing with skilled nursing facility issues. I think there was a lot of movement of changing the settings of care. I think that is a huge opportunity for research to see what has been the impact of that. What are tenets that perhaps would make something like that successful? Where are there potential pitfalls that we need to be looking out for? And so again, utilizing changes, as just one example, changes in settings of care that occurred during the pandemic and what were the outcomes of that, as just one example of where I think research could be very helpful for us to then figure out what makes sense moving forward as we are thinking about care in a more non-traditional sense.
Great, thank you both. We have some questions coming in from the virtual audience, and so we're going to read off a couple of those first.
This question is from Jenny Chin Hansen, and she is the SCAN Health Plan with SCAN Health Plan, and she's the former CEO of the American Geriatric Society. She says, given the emphasis on equity for CMS, how might it address focus and emphasis on African American, Black Medicare, dual eligibles, given the extra high degree of impact of Alzheimer's ADRD on its planning and resource allocation?
I can start. That is an excellent question and an excellent point that I forgot to raise earlier, that, we know that Black people with Medicare have a higher rate of Alzheimer's and dementia than other populations. And so again, where we think about equity with everything, this is no exception. And, it comes back to how we address our day-to-day operations to make sure that we are thinking about culture, about language, about the social environment in which someone is living when we are then providing care. And, making sure, again, even something like graduate medical education and trying to make sure that people are being trained in those communities and in those settings that need those providers the most. So really thinking about it, imbuing equity into our everyday. You know, we are right now going through the steps to be able to collect race and ethnicity data as part of Medicare Advantage and Part D enrollment. That is something, again, that having that kind of data will be so helpful for us as we are then trying to see what is the impact of different things that are, you know, different innovations that are being done. You know, looking at Medicare Advantage and requiring, again, for the duly eligible, those in special needs plans requiring social needs screening and being able to tie that with other data that we can have to see what impact that then has. So hopefully that gives a sense of what you raise is a very good point, where there is this interface between Alzheimer's and, you know, equity, particularly along racial lines.
David, do you want to jump in here?
Yeah, I do. I think also what we're learning more and more is that the communities are really important. And here, that's where a lot of the ethnicity and diversity and local culture really comes into place. And that's why it's particularly important that community-based organizations are paid for the work that they do to help persons who are living with Alzheimer's disease in their families. And at that community level, it's incredibly diverse.
We have a question coming in, looks like, from Bruce Vladeck.
Just in terms of talking about these important issues of equity, I think it's important to remember that the workforce providing in-home care is disproportionately comprised of women of color. And so if you're going to talk about achieving equity in the provision of services to people with Alzheimer's and others in need of long-term home care, we really have to stop sort of talking around these issues of the way in which the workforce that's providing the bulk of home care is compensated, is trained, is treated, is given opportunities for careers and things of that sort. It's not just the patients for whom equity is an important issue, it's the caregivers.
I will just say I think that's an excellent, that is an excellent point. And I know for us, this is where also, both between where we have potential levers, but also working closely with the Health Resources and Services Administration, where there are those opportunities also to support the workforce, either through workforce training and expanding the pipeline, or now through efforts around workforce burnout too, and wellness. Because I agree, you know, you also get with that population the double caregivers, right, where they are caregivers at work and they're caregivers at home, and the impact that that has on their well-being, burnout, attrition, et cetera.
Yeah, somebody comment that the paid caregiver workforce is an extremely complicated issue because many of these people do not have benefits, healthcare benefits. Many of them are immigrant populations, have very little in the way of insurance themselves, and there are immigration issues. It is an extraordinarily complicated issue, but it's one that we need to tackle.
Thanks. Teresa Kim has a question.
Thank you very much, Dr. Reuben and Dr. Seshamani, for discussing both the harrowing financial and livelihood aspects of caregivers and people living with dementia. It's clear that I need, this is an opportunity for me to put forth funding announcements for pragmatic clinical studies for caregiver research and earlier intervention for people living with dementia and their caregivers and see payment outcomes. But in this case, I'm thinking, I feel like there's this wonderful opportunity for payment from CMS where they can incentivize earlier interventions, what Dr. Reuben called, I guess, like the tier 4, tier 5 patients who aren't yet in serious needs of, say, ICU or hospital beds. to get them early treatment for dementia care. But what do we do? And I've had this problem with my own family, with my father being a dementia patient. What do we do when caregivers and people living with dementia are actually in denial of any of these cognitive or functional impairments? We know it would be financially and more physically feasible to get them into care earlier, but and I can imagine that CMS prefers that because it's less costly, but just trying to get my father and my mother to admit that this is now a problem before it becomes so exacerbated. How do we get them in sooner rather than later?
So that's a very interesting and important issue. One of the things that people who develop dementia lose very early on frequently is insight. And they do not have good judgment frequently. And that is something that we do see sometimes at the lower levels of the pyramid. And there is no easy answer for this. What I also tell people and patients that, this is a stage. At some point or another, they will progress through that. And those decisions will be easier because families and caregivers will have to decide for them. But it's very difficult to reason with people with dementia. They don't operate the same way we do in terms of rationale and reasoning. So, if you've seen one person with dementia, you've seen one person with dementia. And that each family has its own resources, and thinking about the person in the past, what they were like before, and see if they will respond to the same cues that they did before. And in a sense, it's just kind of working with the amount of cognition that you have to try to get the right outcome for the patient. But it is not easy, and every case is individual.
Meena, do you want to comment?
I mean, I agree with everything that that David said, and I will say at a high level, when we think about payment and the Medicare program, we want to evaluate everything against the pillars that we all want to drive. Is this something that will advance equity? Is this something that will further that whole person care? And is this something that will enable us to be good stewards of the Medicare program? Where, thinking about waste, fraud, and abuse, but then also thinking about where there are opportunities that if we, for the example that you gave, if you provide care earlier on, does that prevent complications down the road? And that's something that's very important to us as well. And that's, again, where that body of research will be very important across all of these to see, is this something that's really driving where we all want to go?
Thanks. We have one or more comments coming in virtually.
This is from Sharon Inoue, panel member and professor of medicine, HMS. She says, please address the major barriers to implementation of the effective programs for dementia care, given that they save costs and improve quality. What are the 1 to 2 key things that can be done to create change?
Yes, let me address that because a good bit of my life currently is spent trying to disseminate the UCLA Alzheimer's and Dementia Care Program. And I've probably talked to 60 or 70 healthcare systems. And everything goes well. We talk about the benefits. We talk about the model. It all makes sense. And then, and John A. Hartford Foundation has been very supportive of us in doing this. And then the conversation stops about 20 minutes into it because they say, who pays for the nurse practitioner?
David, you're frozen.
But those are a huge barrier for these upfront costs for dividends they may not see personally because the healthcare system or the hospitals reap the benefits. So that's an amazing, important barrier. And the second is training. Training is a huge barrier, and because you don't learn this in school. And then the third is actually getting adequate funding into community-based organizations that can help tremendously, providing personal care, ethnically tailored care. They're critically important players.
Yeah, I mean, I would flip the barriers to the opportunities for improvement, and kind of where you can think about the opportunities for improving is generally along three aspects, and each aspect will have different levers. So the first is statute. So the Medicare program runs by statute, where the law gives us authorities to do some things and doesn't give us authority to do other things. So sometimes when there is an opportunity to improve the program, it's because there actually needs to be a change in the statute, because that's where, things aren't happening right now. The second is kind of that regulatory aspect, right, where there is ability to do something with the statute, but perhaps, this is where the continuous learning and being able to, see where there are opportunities to improve there. And then there's the third avenue, which is then how care plays out on the ground, right? As I mentioned before, if the statute is at the 50,000 foot level, the regulations are at like the 25 or 30,000 foot level, and then you have care being provided on the ground, and where there are opportunities to galvanize the ecosystem of healthcare for the provision of care on the ground, which comes to, aspects of training, and where there are partnerships locally between a community and the healthcare provider, and where you're, engaging more locally in family supports, et cetera. So kind of those are the three aspects, I think, three layers to what then all come together to provide that care to that person.
Okay, we have
Peter Holman from Brown University. I'm not going to be as articulate as Dr. Reuben, who was able to freeze everything up when he said, and then the conversation stops, but I'll try my best to ask a clear question. Early in my career, we started the first Alzheimer's unit in Rhode Island, and we were at a hospital that had taken children with developmental disabilities, and we had educators there on staff. And it was a good model because it was people making the most of living with disability, and although it was a reverse of sort of the developmental stage, we learned a lot from it. I'm wondering whether there are lessons that we could learn from the funding of programs for people with developmental disabilities. We don't necessarily have to worry about education costs and other things, but we have Katie Beckett for people that are not necessarily on Medicaid, that have children with multiple medical issues and handicaps. And I think the biggest challenge that we face, even though Dr. Reuben nicely articulates some of the ones in the Medicare system, is getting payment for the community-based organizations, long-term services supports, things that are generally considered the obligation of the patient and their family, but are not funded, and generally fall upon people that have extraordinarily limited resources, and within just a few months are going to deplete them because they've lost time at work or they're paying for in-home services. So I'm wondering if there are any thoughts about ways that we can more effectively merge Medicare and Medicaid, and also look at other programs like Katie Beckett. Probably Dr. Seshamani would be the person that would be most able to answer that.
We definitely, through our Medicare and Medicaid coordination office, looking to where there are opportunities to improve care for our dually eligible. We put out a regulation recently where, as I mentioned, we're now requiring social needs screenings for the dually eligible, where we are going to have a dually eligible enrollee be part of the governance for these plans, so that way you get that lived experience, and where we continue to partner with the Medicaid program to see where there are opportunities for increased alignment. I visited an ACO, Accountable Care Organization in New York, that specifically focuses on an IDD population, and spoke with them about how, they found that being part of the Accountable Care Organization enabled them to then have those investments in that care infrastructure, with data, et cetera, that, has enabled them to take better care of their patients. And they said there is that Medicaid side where, where we have an opportunity to lay the groundwork that then states can also come to the table and partner so that we can provide that more aligned foundation or infrastructure in which people can care for the dually eligible.
So, Peter, you raised the hundreds of billion-dollar question here. Not everybody who has dementia are dually eligible. Many of them are just above the dually eligible line, and it's a very expensive disease. One of the questions that's going to be extremely difficult is if funds actually are going to flow to community-based organizations. Is that a direct payment from Medicare that has never been approached? Or is it go through the healthcare system, through an accountable care organization or Medicare Advantage plan or another alternative payment model where the money passes through the health system and then is contracted out to community-based organizations? It's two different models, but indeed, those particularly for people who are not dually eligible, this problem has to be solved.
I think this perhaps is one of the most important themes that we're going to hear about for the next day and a half, which is what are the best strategies for scaling what works. And I'd just like to introduce a note of caution here, which is that the healthcare system is just littered with examples of having ideas about what leads to effective scaling that at the end of the day doesn't. And so I think that really probing this one deeply is very important. I think we have another question.
This one comes from Sarah Locke from AARP. She says, it's very rare for a person to only have dementia, often with many comorbidities, and the healthcare provider typically doesn't address dementia because there is the assumption nothing can be done to help the cognitive issue, but the other condition can be managed, so they focus there instead. But the existing dementia makes caring for all other conditions more challenging. What do you think about advising the provider to always consider treating the cognitive behavioral issues first?
Well, the big problem is that the providers frequently aren't capable of doing so. They don't understand the disease, they don't understand the complications, they don't have the resources to do so. They're there to treat the hypertension and the diabetes and the COPD, et cetera. Those are obviously important. That's what gets persons living with dementia in the hospital. On the other hand, this overall dementia care, which coordinates the care, which makes sure that people aren't overtreated or undertreated, the specialists don't have that time or that inclination or the resources. So all those specialty cares are really important, but it's not enough. Obviously, that's why we're in such trouble. They're doing their jobs exceptionally well, but they're not taking care of the patient.
Meena, if you want it, you get the last word here.
No, I mean, I don't think I have anything further to add here.
Okay. Thank you both very much for both your terrific remarks, but also your quick on the feet responses to a range of questions. So thanks a lot. We're going to take a 15-minute break right now, and we'll see you back here at 10:25. Thank you very much.
Thank you, everyone.
Thank you.